So again, thank you all for coming. It's again a pleasure to be in front of you this morning to talk to you about transfusion overuse, which is a patient safety issue. To kick off this session, which has again some great speakers. So I think this meeting is going to be a rocking meeting. I again honored to share the podium with those speakers who will come after me. Just very quickly, I think also the organization of this meeting, the staff that works with Cherry, the department members, all of them deserve a hand for putting all this together. And you'll see at the end of the day, it's going to be great. So I'll talk to you a little bit about transfusion overuse because we're all limited for the amount of time that we can address the topics that we have assigned to us today, especially in this summer day in November. I've asked the technician to see about cooling the room a bit so that it feels like November. Anyway, going back to this issue, is there overuse? And then how much overuse is there if we decide that there is overuse of transfusion? And does transfusion overuse fit into the overuse model, the medical model of transfusion overuse, or overuse altogether? And then, of course, we're going to ask what can be done if we agree that there is overuse, and are we asking then the right questions to get the right answers when it comes to dealing with overuse? So as I mentioned to you already, overuse may be an issue in terms of patient safety. And when we look at overuse, which has been actually described early on in 1980 by the Institute of Medicine, and I'll go over the definition in the next slide, but you could see that it has a potential of doing harm to patients. It has excessive cost not only to society but to healthcare, defies patients' preferences. Many times patients expect that what's being done to them actually is going to yield benefit and not just risk. And of course, it affects healthcare quality, which again, the backside of which is patient safety. So again, the definition of overuse, as you could see, is the use of health services in circumstances where the likelihood of benefit is negligible and therefore patients face only the risk of harm. This definition has been carried over both by the Joint Commission as well as the AMA. As a result of concerns in terms of overuse in healthcare, both the AMA, Physician Consortium on Performance Improvement, as well as the Joint Commission got together, these two organizations, and put together what's called the National Summit on Overuse, as you could see. This took place in September of 24 of 2012 and has since then been published by the Joint Commission in conjunction with the AMA. And you could see that transfusion is not the only thing on this list, and this list is essentially the initiation of this summit, if you will. There are many other areas in healthcare where there's overuse, but they started with elective PCI. Those of you who don't know, it's percutaneous coronary intervention. So it's elective, and there's a significant amount of cost as well as patient safety issues associated with that procedure. Myrigotomy and tubes in the pediatric population, where again there are some strict guidelines which are not adhered to, and in fact there is an enormous amount of overuse without any benefit, and under those circumstances we're only conferring risk. Early cesarean section, over 30% in the United States. That is at 39 weeks rather than at the end of gestation, if you will. And then antimicrobials for upper respiratory infection. I don't know how many of you in the audience have finished your Z-Pak, but in fact, we know that over 90% of those infections are actually viral. But for some reason, we continue to prescribe these antibiotics, which are broad-spectrum antibiotics, and again, have given rise to resistant organisms with some significant morbidity and mortality for those patients who have been affected by that. So you could see that blood transfusion is on that list. There was no hierarchy in terms of which came first. They all were treated equally in terms of this particular summit. Now, some of you may be aware of the American Board of Internal Medicine 2012 Choosing Wisely campaign, where they've asked every professional organization to come up with 5 items of do nots. Again, trying to corral, if you will, not necessarily overuse per se, but things that can confer risk to the patient. So this, again, is shared with the public, and I think my slides are moving automatically. Shared with the public, and just as an example, giving one slide here where we took the Society of Hospital Medicine, one of the fastest growing organizations in the United States of physicians, and you could see from there, Choosing Wisely campaign, one of the 5, this is number 3, one of the 5 do not is avoid transfusion of red cells for arbitrary hemoglobin or hematocrit thresholds and in the absence of symptoms of active coronary heart failure or stroke. The idea, again, behind this is that almost every one of the professional organizations, maybe psychiatry and maybe the one representing dermatology, has some encounter with transfusion medicine. And in fact, many more of these organizations have something to do with transfusion and trying to align the patient's needs and hence the patient's preference with what we do as clinicians. Many of you may or may not know, but this actually happens to have an old slide. There's a new publication of the U.S. Department of Health and Human Services in conjunction with AABB, the National Blood Collection and Utilization Survey, and we've gone down from about 14.5 million units that transfused annually to somewhere in 13 million. So the number is going down. In 2006, we were just above 50 units per 1,000. This is how we compare one country to another. And at this point, the U.S. is down to 48 per 1,000, or maybe even slightly less than that. But the fact of the matter is we still lead the world in the amount of red cell transfused per 1,000 population. So it is a good place to be, always in first place, but sometimes it's not, and this may not be a preferred first place to be in. HRQ, again, published looking at transfusion, and you could see they occur in 1 in 10 of all hospital stays that have a procedure done. And our Supreme Court in the United States has determined that transfusion is an invasive procedure. So you could see, again, we perform quite a few of these, and one of the fastest growing top 5 procedures in hospitalized patients. You see that below that on the slide it says consumption of safety. The consumption of safety philosophy or principle is one where as we make things safe, quote unquote, we consume the safety because of our behavior. If you, well, many in the audience probably don't remember, but if you would be driving a 1957 Chevy down the highway, you'd be sure to have enough room between you and the car ahead of you so that there'll be plenty of time to brake because you had no seat belts, you had no analog brakes, you had no airbags, crush zones, and all the other issues of safety that we have today. Driving a 2013 vehicle that has everything in it, we end up texting. So you could see how you can consume the safety, and this may be one of the areas of why we're seeing overuse is the consumption of safety. So turning to the question, is there overuse? Again, if you look at the literature, and I'm only going to show one slide because of time, but there's publications out there that have pointed to the fact that there's probably anywhere between 40 to up to 60% overuse. But if you look at the inverse relationship, where actually you can reduce the amount of transfusion in a single institution or even in multiple institutions without having any negative outcome, and sometimes actually demonstrating positive outcome, you could see that reduction 12 to 83% in one publication, 9 to 77% reduction of red cell use in another publication, and of course a reduction of more than 85% of fresh frozen plasma in another. And you could see again that if you look at it from the inverse point of view, there is a significant amount of overuse. In 2011, in Transfusion Medicine Review, this article was published looking at the International Consensus Conference on Transfusion Appropriateness, and you could see that there is a high frequency of where transfusions were considered to be inappropriate. 50% There were over 30,000 citations that were looked at, ended up with close to 500 that actually had outcome of transfusion associated in the publication. And then using the Rand-Delphi UCLA methodology, which is a consensus, agreed upon consensus process where disagreement can actually be managed rather than completely reducing everything to the lowest common denominator. There were 450 clinical scenarios where patients who are hospitalized get transfused, and none of those include hemorrhage. So again, appropriate was defined as improving the patient's health. Inappropriate was defined as demonstrating the patient actually ended up with a negative outcome. And uncertain meant there was no discernible benefit, therefore only risks the patient. And as far as I know, this is probably one of the only publications where patients who actually benefited from transfusions were defined, albeit being a very small percentage. As you could see from this pie diagram, it's only 12%, whereas 88% were either harmful to the patient with negative outcome or associated with actually no benefit. One of the other areas that we see as associated with overuse is the variability of transfusion, and this goes back to 1991. And I will say that almost every decade there's a large trial out there that gets published looking at variability of transfusion, and since 1991, and we're not starting actually at the beginning of these publications, to up to 2013, we have not been able to demonstrate any improvement in the variability. So these 18 hospitals, 30 patients in each undergoing coronary artery bypass graft. All the patients were matched for the type of surgery, their underlying medical condition, so everyone was matched, including for their blood loss. And you could see that if you went to hospital number 1, on the left of the slide, the amount of transfusion that was received for the same surgery with the same blood loss was extremely low as compared to hospitals 17 and 18, where you basically got blood no matter what. In another study that was European, where it was funded by the Austrian government, looking again at variability of transfusion, this was looked at different hospitals and different procedures: total knee, total hip, colon, and coronary artery bypass grafting. And here again, you could see with a similar modality, 16 hospitals. This is total knee replacement. You could see that hospital number 1 is just slightly higher than 10% transfusion for the same procedure, whereas hospital number 16 is close to 90% transfusion. So you can draw a line of potential of overuse anywhere you'd like from here, but as you could see that there is enormous amount not only of variability, but also potential in terms of reducing this overuse. Just moving on to this decade, this is another study looking at over 780 hospitals in the United States, again coronary artery bypass grafting, and you could see variability of red cell transfusion anywhere from 0 to as close to 100% transfusion. So this behavior repeats itself over and over without us having any improvement. So we've established that there's enormous variability, if you will, with red cell transfusion, which doesn't always make sense. And it gives you this sense, of course, that transfusion is no longer a science by any means, it's a behavioral activity. And when you look at transfusion of plasma, you could see again enormous variability, but when you look at plasma compared to red cells, it makes red cells look like a science when you're using plasma, and when you look at platelets with the same variability, it may actually make plasma look like a science. Now, going into this year, this is again variability or variation of blood transfusion patients undergoing major non-cardiac surgery. So we've looked at the cardiac patients, and here again you could see with a significant variability between institutions and intra-institution. In hip surgery, this is in colon surgery, and then of course in Whipple and pancreatiduodenectomy surgery. So this persists without any change, despite the fact that we keep examining the same area over and over again. Well, rest assured, this is not new. This is something that's been with us for quite a while. Some of you may be familiar with this publication. This is the New England Journal of Medicine, and you could see this. This is a September 1936 publication, and on the bottom I've highlighted for you the use and abuse of blood transfusion. There's nothing new under the sun. When we talk about overuse and we are looking at the concept of if overuse in healthcare, which I've defined for you, we could look at three topics, if you will, that have been created to address this concept. And one of them is benefit-harm trade-off, meaning the potential harm exceeds the potential of benefit. This is part of what we described in a definition, and therefore the services should not be delivered. So this is a little more proactive. Benefit-cost trade-off services where the magnitude of the potential benefit is small relatively to the amount of money or energy spent or cost, if you will. And then considering patients' preferences, the trade-off between outcomes such as survival, quality of life, and the shared decision-making principle. Now, as clinicians, we are always looking at survival as our endpoint, which may be not the right endpoint for many of our patients who are actually looking for a quality of life. And there are studies out there where the actual the outcome that the clinicians were looking at were completely irrelevant to the patient. Now, it doesn't necessarily make one right and one wrong. It's the fact that they're not aligned is important for us to understand. And there are situations where they are aligned. I think that what we're trying to achieve right now, whether it's through the Affordable Care Act or any other ways in terms of improving our relationship with the patient, is to align the patient's desires for outcome with ours. Now, it can't always be done, but it's worth a conversation so that the clinician knows what the patient is expecting versus what we expect, which is, again, mostly survival. And of course, a reduction in complication. So what I'd like to do in the next, with the next few slides is actually take each one of these and show you where we are when it comes to this issue. So the potential harm exceeds the potential benefit, and therefore the services should not be delivered, is a very, very strong statement. And when we look at blood transfusion, we are constantly consumed by the issue of the product, and the product in terms of safety. So there are two levels of risks associated with transfusion. One is the infectious complications associated with them, and I'm not going to take the time to go into detail, but you could see that there are statistical consideration in terms of the risk that a transfusion of red cells or any blood component may have. And these are the infectious agents that we test for. There are many out there that we don't test for. And when we talk to our colleagues in transfusion medicine, what reverberates the fact that we're maybe just one day away from another epidemic that we had with HIV. We just don't know what the next organism is going to look like. But if it's a slow organism that, again, is transmitted through transfusion that can cause significant morbidity and mortality, that is a threat that we live with constantly when it comes to infectious risk, even though we've been able to reduce those that are on this list considerably. It is the non-infectious risks which I think are the ones that bother us the most right now. These are, again, all have to do with the immune response of both the host, meaning the recipient, as well as what we're delivering in terms of a unit of blood. And immune modulation, which is the response of the recipient's immune system to the unit of blood, which is a foreign substance, is called immune modulation. We can't get our arms completely around it in terms of what it causes, but it is probably associated with a slew of negative outcomes. And again, not to go through all of this, but we can prospectively tell you the damage that can occur as a population. We can't identify the patient ahead of time, but we may get to the point where we can identify patients and again, try to avert some of these complications. So keep in mind that there's infectious and non-infectious risks that are associated with allogeneic transfusion. And the transfusion medicine people have known that for quite a while. This is Tom Zuck's statement to U.S. Congress, changing transfusion or blood products in the United States to a service because of product liability in the 1980s with the HIV and hepatitis C epidemic. And he used the terms that blood is unavoidably unsafe and blood is inherently dangerous to convert that from a product to a service. This is data from ICTO, the International Consensus of Transfusion Outcome. Again, looking at the different articles out there. What red tells you adverse outcome. The yellowish is no difference, and the blue is mixed, where there's potential for benefit. And it's hard for any of you to pick out the blue. You may be able to pick up a yellow, or yellowish green, but you could see that the preponderance is there in red. And this has been done more than once, and we know that there's more and more in the literature to support, again, the negative outcome of transfusion, especially to someone who can be managed differently. And what clinicians are unaware of is the fact that each unit can and does cause alloimmunization. Some of it, or allosensitization, some of it may not be clinical significant, but the risk remains there that if the patient does require a unit of blood and receive the unit that could be avoided, you could see the potential harm that we can cause for these patients. And again, not to scare anyone, but there's also now data in terms of transfusion and necrotizing enterocolitis, or the Trowny, I think it's called, but this has now been established, if you will, as one of the risk factors associated with transfusion in premature infants and neonates. And what amazes me is these types of publications that we see in the literature. This one is from American Heart Journal, looking at blood transfusion for acute decompensated heart failure, friend or foe. And you could see these are all prominent cardiology people. I'm just going to bring you all the way to the conclusion, and you could see the blood transfusion in acute decompensated heart failure seems to be safe. But there's not a single word about benefit in these publications. So again, looking at this from a harm or risk-benefit ratio, anytime a patient receives a unit that is not indicated and is predicated on multiple reasons, not just a feeling or behavior, as you could see with the variability, we are just conferring risk to those patients. Looking at the cost issue, this again is data which is the acquisition cost of blood by institutions. This is data from this country, and you could see that there is a constant rise, if you will, that is passed on to the consumer. And the rise in cost is due to the sophisticated testing that we do, making, quote unquote, the blood product safe. So it's the delivery of the blood to the institution, which is, again, rising costs, but somewhat contained, and also with, quote unquote, a safe product. It's the hands of the users that make this a dangerous venture for many recipients. In another large study, they're looking at the frequency and outcome of blood product transfusion across procedures and then clinical conditions warranting inpatient care. This analysis, again, yielded some other negative, if you will, press, because although the numbers in this article, I think, are lower and probably misquoted, 5.8% or 2.3 million transfused is lower than what we know at the time of publication. But you could see that there's a 1.7 increase odds of death, 1.9 increase odds of infection, 2.5 days longer length of stay, and you could see that the charges per patient who's transfused are higher. And when you look at this in aggregate, that could be a significant number of dollars. I know we've gotten used to trillions, but I think that $1 billion is still a large number. The fact, again, is that hospital administrators are looking at the one side of it, at the variability of transfusion, and the other side, the cost of the institution, in times when we're trying to contain healthcare costs. And you could see that there is now reason for them to look for other modalities, patient blood management being one of them. Now, the precautionary principle, which is applied in transfusion medicine, I don't think is extended to anywhere else in healthcare with such degree. And this was Jackson's data and Mike Bush looking in 2003 at the NAT testing for HIV, hepatitis C, and hepatitis B. And again, you could see that the disease avoidance, albeit for the individual, may be significant, but we're looking in terms of populations, and we're talking in terms of risk to population, there's a reduction of 4 to 7 infections with HIV, close to 60 in hepatitis C, and somewhere around 30 infections of hepatitis B, at a cost of anywhere from $4.7 to $11.2 million per quality life, adjusted life year. And again, at the time of publication, coronary artery bypass graft was the benchmark at $50,000 quality adjusted life year. This does not include some of what you see on this slide, which is the cost incurred to donors, the cost of treating adverse transfusion events, cost of treating transfusion-transmitted diseases, the cost of litigation, and loss of productivity of those individuals who are harmed either by donation or harmed by the recipient of, or as recipients of blood transfusion. So in 2000, we went to the NIH to ask how much does it cost to transfuse a unit of blood, because we had data on what it cost to buy the blood. And lo and behold, we were surprised to find out that no one knew. And after 7 years and lots of money, we're able to put this study together with my colleagues. And you could see this looks at 4 hospitals, 2 in the United States, 2 in Europe, so it's adjusted for those years of the study. 2 hospitals were academic institutions, 2 were community. There was a computerized blood bank versus non-computerized blood bank. And what we found out is that the cost of procuring blood, meaning buying the unit of blood by hospitals, varied, but not significantly from one place to another, and that's depicted in the red cylinder. The blue cylinder is the cost of transfusing a single unit of blood to the surgical population. You could see that now we're talking anywhere from 3.5 to as high as 4.5 times the cost of procuring blood. So the transfusion is extremely costly to institutions. And the orange cylinders represent the cost of treating a surgical patient who's transfused. So these costs are escalating, if you will, and these costs need to be contained, and especially with the background of understanding that there's significant variability without benefit to patients. These costs now certainly are being looked at by most hospitals as avoidable. The idea, again, is that transfusion is an act that occurs at the bedside with the patient. And for the blood centers, their concern is not at the bedside. Because for blood center, what they're only looking at is safety. Again, producing a safe product, if you will, and delivering on time and making it compatible. It is not what we have to be concerned with, which is the patient. So on the side of the transfusion act, if you will, within hospitals at the bedside, it's the patient that's paramount because the safety has been established already. The third part of what we call overuse is the consideration of patient preference, and you could see that he's not always been very happy with us. But it is the trade-off between outcomes such as survival and quality of life, the shared decision-making principle, which doesn't necessarily mean that the patient is making the decision. The patient brings to the table their needs, wants, and expectations, and it behooves us not only to listen, but to align with them as much as we can. And there is now more and more data in terms of alignment. I can give you many examples, but I just don't have the time, where the expectations of physician, whether it be through cardiac surgery or intervention through cardiology, is very different than what the expectation of patient is. And some patients would have trade-offs. They'd rather have a higher quality of life than the longevity that may come with low quality of life. So keep in mind, for us, it may be different than what the patient actually desires. And where we can, we should not only listen, but implement that. So how do we come to discuss things with patients if we don't know what we're talking about? So here's an example. This is Julie Karp's work, and Julie, when she was a fellow, did this survey of transfusion medicine in undergraduate medical education. And we did say that transfusion is one of the most common procedures in hospitalized patients. She surveyed 86 American medical schools. 83% of the educators, these educational administrators of education, these are deans, reported back, which is a very robust response. You could see that half of the medical schools close to, reported that there was 1 to 2 hours of training on one of the most common procedures done in patients who are hospitalized. Keep in mind, these are 4 years of medical school in the United States as average. 1 or 2 hours on ABO compatibility, which is really something the blood bank does without knowing anything about benefit-risk ratios, is insufficient. Worse is that when the administrators of education, the so-called deans of education, were asked, you could see that 88% of them knew anything about the 1989 or the 1999 Transfusion Medicine Academic Award curricula. So not only are you getting 1 to 2 hours as a medical student in terms of transfusion medicine, the information you're getting is probably wrong. And as evident in another study that was done, this is from Boston, the influence of knowledge and attitude and the quality of physician transfusion practice. And to make a long story short, you could see that the more you know, the less you transfuse, the less you know, the more you transfuse. So it's inversely related. Those of you in the audience, physicians and nurses, are well aware of the fact that the attending physicians had lower knowledge scores but greater confidence. So this is, again, eminence-based medicine. And again, you see that the residents admitted that more than 60% of the time they were transfusing a patient because of attending pressure. And you probably all have heard this, that I would feel better if my patient's hemoglobin was higher, nothing to do with the patient. So here we are with those 3 concepts, which I think are the hallmark of overuse: the benefit-harm, the benefit-cost, and the consideration of patient's preference. So how do we mend this problem? So the first question, of course, is, are we asking the right question? And we're seeing a slew of liberal versus restrictive transfusion, but what we really need is transfusion versus other modalities. Enough with the liberal versus restrictive, but it seems to me that we're sort of addicted to that process, and we're seeing more and more of that. Now, somebody from southern New Jersey, Princeton, used to say that asking the same question or doing the same thing over and over again and expecting different results is the definition of insanity. So I don't think we are insane, but are we asking the right questions? And just to show you how sometimes a mind can play tricks on us, these are actually real headlines, if you will, from newspapers. The first one is, statistics show that teen pregnancy drops off significantly after age 25. And of course, when your expectations are not aligned, you'd be surprised that the federal agents raid a gun shop and find weapons. So again, you could see that asking these questions is paramount to a solution. And just to show you, this is just a quick summary of restrictive versus liberal transfusion. You could see, again, this is from 13. You could see all of them answer in the same fashion. Liberal, better than, liberal is worse than restrictive. Restrictive is the way to go. The new guidelines constantly call for restrictive transfusion practice. And again, this is even in bleeding patients, which we've been sort of hesitant to address. This is the New England Journal of Medicine earlier this year looking at transfusion strategies for upper gastrointestinal bleeding. And again, although the endpoint may be the wrong one, still in terms of survival, you could see that the liberal do worse than the restrictive. So this is the beginning, if you will, of now looking at the bleeding patients. We've known in trauma that large amounts of transfusion actually end up with worse outcome. So those of you who are thirsty for more liberal versus transfusion, don't worry. There's more coming. These, again, registered trials that are ongoing in terms of transfusion, restrictive versus liberal transfusion. And from my good friend down the road from UMDNJ and Robert Wood Johnson, this is the pilot study of looking at, again, liberal versus restrictive transfusion threshold for patients with symptomatic coronary artery disease. And unfortunately, Jeff, I know, is biased towards liberal in this particular situation versus restrictive, but they found no difference. But again, there was slight trend towards liberal transfusion, and all I say to Jeff is, he's really trying hard. So where are we? What do we do? Well, we ask the wrong questions, we get the wrong answers, but we keep doing that over and over again. So doing things over and over again is very helpful, so now we turn to guidelines. And here are the guidelines. So if you think there aren't enough guidelines, just take a look at this table. And again, 40% of these guidelines, more importantly, do not have a threshold, or so-called, people call it a trigger, a threshold of hemoglobin. As a matter of fact, they refrain from giving one and recommend that you don't use one for indication of a transfusion. But I think we have plenty of guidelines, and guess what? There are more coming. So with that, I could tell you that this is hot off the press. We shamelessly do not follow guidelines. The highest rate of following guidelines is around 7%. Knowledge of existence of guideline is worse. So we're all looking at guidelines of transfusion. And I think that we need to look at the target. What is it that we're treating? What is the disease that we're treating? And I think that the only way to look at it comes through patient blood management. And some of my good friends are in the audience, but as you could see in Australia, and I know you don't think they know what they're doing because they're upside down, but in fact, they do. And what they've done is they've abandoned transfusion guidelines in favor of patient blood management guidelines. There are 6 module, 4 are represented over here, and they address, again, the preemptive approach to the patient's problem rather than transfusion as a trigger. So I think that that is changing. But as I'm winding down, I think that it's very important for you to see this particular article that was published, because I think that drives home the fact that transfusion not only is variability, but there's enormous overuse, but that there's no science behind this. This is a behavioral problem. This is, again, a study protocol using theories of behavior to understand transfusion prescribing in 3 clinical contexts in 2 countries. Those are UK and Canada. Just talks about, and those of you in the audience who know the group of individuals, clearly they're heavy hitters in transfusion medicine. So there again, I think through this title admit that there is no science, that this is behavioral. And what's sad when we talk about overuse is data, again, this is from Steve Frank at Hopkins, that 1/3 of transfusions intraoperatively are done without any objective findings. It's really done on feel. And whether the outcomes are good or bad is a whole other issue, but just to show you that the behavior is a problem. So what are the mechanisms of transfusion overuse? Well, there's poor education. There's a poor culture. We concentrate on the product and not on the patient's needs. There's a lack of regulation and payment. There's a lot of money for product safety, but nothing for prevention. Missing objective decision-making aids. Again, we have a lot of measures out there, but few aids for clinicians. So I'll conclude by showing you who's at risk. And this was published, but as a schematic diagram of those at risk. You can see on the left where blood saves lives, and we tell our trauma surgeons that that's not the case. Blood can be part of the armamentarium of resuscitation, but if blood saved the lives, we wouldn't need you. In fact, we know someone has to stop the bleeding. This population is small and, in fact, can only be addressed retrospectively. On the other side of the slide on the right, we know that whether it be trolley or a incompatible unit of blood causing fatal hemolysis, we can tell you the frequency. We can't tell you which is the patient, but we know prospectively who's as a population who's at risk. But the large part of this Gaussian distribution lies with hospitalized patients receiving between 1 and 3 units of red cells. We're not talking about plasma today. We're not talking about platelets, which is a whole other area of overuse. So I leave you with a definition of patient blood management, and you could see again where the patient is in the center. It is the timely application of evidence-based medical and surgical concepts designed to manage anemia, optimize hemostasis, and minimize blood loss and blood transfusion in order to improve patient outcome. And the Society for the Advancement of Blood Management has put together the 4 quadrants, which is looking at optimization of coagulation, interdisciplinary blood conservation modalities, something that is completely ignored in many institutions. There's more blood in the drain than there is in some patients' veins. Managing anemia. Anemia is an epidemic, according to the WHO. And again, patient-centered decision-making, which I think I addressed with you. But most importantly, this is an improved patient outcome-driven process. If we cannot demonstrate that patients do better with proactive care, then again, I don't think we should be embarking on this. We have been able to demonstrate that, and my colleagues who are following me will show you some of the data. Thank you.